In this snippet, we will be discussing a very classical scenario. We have here a 52-year-old female who presented to us with a very peculiar complaint, which initially looked like a radiculopathy, cervical radiculopathy. मौसी आपको क्या तकलीफ होती है?
ये तो निपुण हाथ टनकते हैं,
हाँ,
आग है चटनी सारखी, ये खादों की छाता मांगून दुखते हैं.
She is complaining of pain in the shoulder, which is burning in quality, plus pain in the anterior chest wall in the upper half of the chest and posterior shoulder blade. और वो कैसा होता है? जलन जैसा होता है क्या?
हाँ,
जल
चटनी सारखा.
चटनी सर मीन्स इट्स रेडिएटिंग पेन, लैंसेटिंग टाइप ऑफ पेन. किधर जाता है? इतनी इकडे पुढे जाता है.
हाँ.
ये पूर्ण हाथ जाता है कि इकडे जाता है कि इकडे जाता है? So she is pointing to the medial aspect, and ये उंगली में भी जाता है क्या? She is pointing that this burning radicular pain involving the shoulder blade, anterior part of the chest, it is radiating through this dermatomal distribution up to these two little fingers, that is the ring finger and little finger. As you can see anatomically, this is the C8 T1 distribution, and this is a radicular pain involving the C8 and T1 distribution. So initially we thought that it is the radiculopathy mathematically. Now the next clinical presentation was, if you close up, you can see here there is wasting of the intrinsic muscles of the hand of the corresponding side of the pain. You can see here there is wasting as compared to this. This is more hollow. There is wasting of the intrinsic muscles of the hand with this radicular pain. मान ऐसा करने में तकलीफ होती है क्या? ऐसा करने में झुंझुनी होती है क्या? ऐसा करने में ज़्यादा झुंझुनी. When I am doing this, she is feeling that pain increasing. Maybe it is the stretching of the C8T1 distribution. That is the lower part of the brachial plexus C8T1. But what came out interesting after the examination of the respiratory system, there was bronchial breathing. There was bronchial breathing in the suprascapular area and on the infraclavicular area, and the supramammary or the infraclavicular area there was a bronchial breathing, and we did a HRCT thorax. Now we will be discussing what we saw in the HRCT thorax.
Good evening, I am Dr. Priyal, I am the radiologist. Let us learn about the HRCT thorax features of the patient that you just heard about. So these are axial sections of HRCT thorax. These are the lung windows, this is the mediastinal window. So on this lung window, we see that there is evidence of a large, well-defined soft tissue density mass lesion in the left apicoposterior segment of the left upper lobe. Now this mass lesion, as we can see as we go down craniocaudally, it is occupying almost all of the upper lobe, extending into the posterior anterior segment of the left upper lobe. Now the rest of the lung fields appear grossly normal. When we come to the mediastinal window, in this mediastinal window, the superior extension of the lesion is well identified. It is extending superiorly up to the supraclavicular lesion on the region on the left side, and we see a calcific focus. As we go further down, we see that the lesion has posteriorly invaded into the first and the second ribs on the left side. On going further down, the lesion is medially abutting the arch of the aorta. As we go further down, we see that laterally it is extending into the intercostal muscles on the left side. The rest of the mediastinal window shows no obvious abnormality. There are some subcentimetric lymph nodes which are noted in the mediastinal region. So all of these features point towards a diagnosis of possibly Pancoast tumor on the left side of the lung.
So basically we talked to the patient, her symptoms, examination findings were depicted. Now the radiologist described the HRCT finding, and the final diagnosis was Pancoast-Tobias syndrome. So what was there is the radiculopathy was due to a tumor which was sitting on the lung apex, that is also known as the superior sulcus tumor, that is known as the Pancoast tumor. It was sitting on the lung apex. This engineering drawing is just depicting how the structures, that is the first rib, the second rib, and the cervical C8T1 brachial plexus is getting compressed. Along with, we also saw that the vascular sheath was also been abutted by the tumor there. That was the clinical presentation. So very rarely these radicular pains, especially the C8T1 root, one should be suspicious of getting a respiratory system examination very thoroughly, because one of the rarest presentation can be Pancoast tumor, and usually these tumor do not present with the conventional clinical presentations of cough, sputum or hemoptysis or breathlessness. They usually present with the radicular symptoms. One interesting thing, so when we talk about the Pancoast tumor, it causes the Pancoast syndrome. So the Pancoast syndrome consists of compression of the brachial plexus leading to radiculopathy. So the classical lancetating distributive pain in the medial aspect of the arm and forearm, and there was also thinning of the intrinsic hand muscles on the left side of the patient. And on the radiological finding, we also know that the first and second rib had been destroyed and aborted by the tumor. This is one, and the second important thing is involvement of sympathetic chain, because this is the area of the cervical sympathetic chain also. And usually these patients present with Horner syndrome. Though in our patient there was no Horner syndrome, maybe the cervical sympathetic plexus was not involved, but the other features of Pancoast syndrome, that is also known as the Pancoast-Tobias syndrome, was present. So concluding, the Pancoast syndrome consists of one, that is the compression of the brachial plexus lower roots, that is C8T1, and the radicular pain and intrinsic hand muscle vestings. Secondly, Horner syndrome on the ipsilateral side. Thirdly, radiologically you can also demarcate the involvement of the first and second rib. That's why the patient was complaining of pain and tenderness in the upper part of the anterior chest. So this is in brief what is a Pancoast syndrome and due to a Pancoast tumor. Usually the Pancoast tumor, they are non-small cell lung cancers, most commonly adenocarcinomas followed by squamous cell carcinomas, and the basic treatment here it's a team effort from the physician to oncologist, thoracic surgeon and everybody. So the usual management will be, now we will go for a transthoracic aspiration, and if it is inconclusive then a thoracotomy and biopsy, and after the results the usual management protocol is chemoradiation and or surgery. Thank you.